A 35-year-old female presents with lower leg pain, swelling, and a low-grade fever. I am showing you radiographs of the leg and coronal T1, coronal stir, and post-contrast axial magnetic resonance images of the tibia. Please describe the findings.
The radiographs demonstrate a permeative, moth-eaten osteolytic lesion in the distal tibial metadiaphysis with aggressive periosteal reaction. The magnetic resonance images reveal extensive marrow infiltration and a large surrounding soft tissue component extending through multiple microscopic cortical vascular channels.
What is your primary diagnostic concern?
The findings of a highly aggressive, permeative metadiaphyseal bone lesion with a large associated soft tissue mass in a young adult are highly concerning for Ewing sarcoma.
What is the cell of origin and the characteristic genetic translocation associated with Ewing sarcoma?
Ewing sarcoma is a malignant small round blue cell tumor of neuroectodermal origin. It is classically associated with the T translocation, which creates the EWS-FLI1 fusion gene.
How does Ewing sarcoma typically extend from the intramedullary space into the surrounding soft tissues? And how does this appear on computed tomography or magnetic resonance imaging?
It extends through microscopic vascular channels within the cortex, rather than causing a single large area of gross cortical destruction. On computed tomography or magnetic resonance, this appears as multiple small, linear cortical channels with a large, contiguous extraosseous soft tissue mass.
What type of periosteal reactions are typically associated with this tumor?
It characteristically incites aggressive periosteal reactions, including a lamellated or onion skin appearance, a sunburst or hair-on-end pattern, or a Codman's triangle at the lesion margins.
Where does this tumor most commonly occur in the skeleton, and how does its location in long bones differ from osteosarcoma?
60% occur in long bones, most commonly the femur, tibia, and humerus, where it typically affects the diaphysis or metadiaphysis. Unlike osteosarcoma, which is predominantly metaphyseal, Ewing sarcoma has a stronger predilection for the diaphysis.
Why is this tumor frequently misdiagnosed as acute osteomyelitis clinically?
It often presents with systemic symptoms such as fever, localized warmth, swelling, leukocytosis, and an elevated erythrocyte sedimentation rate, which closely mimic an acute infectious process.
Finally, what are your clinical management recommendations?
I recommend an image-guided core biopsy to confirm the diagnosis, staging with a chest computed tomography and bone scan to evaluate for pulmonary or skeletal metastases, and referral for neoadjuvant chemotherapy followed by local control.